So next we have Dr. Noopur Dubey. She will be presenting DSEK in case of failed PKs.
So good morning all. My topic of presentation is DSEK in failed rehabilitations and outcomes. Despite the increasing success of penetrating keratoplasty, graft failure remains a very important problem. There are two options for visual rehabilitation. Either we can plan a repeat penetrating keratoplasty, which has a long-term survival rate of 21% to 70% in such cases, or we can go ahead with an endothelial keratoplasty. These are the advantages and disadvantages of doing a DSEK in a failed graft. Most significant being advantage being less chances of intra-op complication, especially expulsive choroidal hemorrhage. So we decided to conduct a retrospective study to report the visual outcome and graft survival of manual DSEK in cases of failed PK grafts in a tertiary care center. We included all cases of DSEK done in failed PK grafts with a minimum follow-up period of 4 months. All the cases were operated by a single surgeon and DSEK graft preparation was done manually. This was the data which was collected for our study. Coming on to the results, so we included a total number of 8 patients. Mean age was 48.12 with age ranging from 28 to 64. 75% of our patients were male. Most common indication for initial PK was non-healing corneal ulcer in 37.5% of our cases, followed by perforated corneal ulcer and a corneal scar. Initial PK diameter was 8 mm in 37.5% of the cases. All our patients had undergone only one previous PK. If we talk about the rejection episode, then 3 patients were not aware of any rejection episode before PK failure, as they were referred to us from outside. 3 patients had one rejection episode and 2 patients had no history of any rejection episode before PK failure. If we talk about the DSEK donor diameter, then it was 7.5 mm in 62.5% of the cases. Decimet stripping was done in 62.5% of our cases. If we talk about the lens status, then 50% of the patients had cataract, 2 patients were pseudophakic, 1 patient who was very young had a clear crystalline lens, and 1 patient had an anteriorly dislocated PCIOL. In the patient with a clear crystalline lens, we performed a phakic DSEK, and in the patient with an anteriorly dislocated PCIOL, we performed a DSEK with IOL explantation with pars plana vitrectomy along with a scleral fixation of the IOL. So if we compare the pre-op visual acuity and post-op visual acuity at 4 months, then we can see that in most of the patients, the visual acuity did improve. In fact, we were able to achieve more than Snell and best corrected visual acuity of more than or equals to 6/18 in 50% of the patient. In 2 patients, the visual acuity did not improve much. 1 patient was later on found to have a macular scar, and 1 patient along the course of the treatment developed a fungal keratitis and ended up with a poor visual outcome. So this is the pre-op and the post-op image of the patient who underwent a DSEK with an IOL exchange. This patient had, in this patient on POD5, an inferior graft detachment was noted, which was successfully managed with the rebubbling procedure. This is the pre-op and the post-op image of the patient who underwent a phakic DSEK with us. And this is the patient who underwent a non-Descemet stripping DSEK, which shows that even if we choose to not strip DM, in some cases, the results are equally good. This is the patient who underwent, who in spite of having a clear graft ended up with a poor visual outcome due to a macular scar which we were unaware of. This is the patient who after an initial period of graft clearing developed a fungal keratitis and had a BCVA of county finger at 1 meter at the end of 4 months. So to summarize, in our study, indication for initial PK was either non-healing corneal ulcer or perforated corneal ulcer in maximum number of cases, which is in contrast to most of the published literature from the Western world, where most of the cases are done in post-optical PK cases. DSEK donor diameter was smaller than the PK graft diameter in all our cases, which is again in contrast to most of the published literature from Western world, but similar to the studies done by Strico et al. And Chaurasia et al. In our study, DM stripping was done in most of the cases, again for the same reason that most TKP grafts were higher. In our study, 5% of the cases, which is similar to the published literature. The incidence of graft failure varies from 9% to 16.6% in similar studies, but none of our patients developed primary graft failure in our study. Now this thing can be attributed to a smaller sample size. So to conclude, DSEK is a viable option for visual rehabilitation of a failed visual acuity may be suboptimal, especially in the cases with the failed TKP grafts. The other benefits may still outweigh the risk associated with the repeat PK. We need to be really vigilant about the chronic steroid use related side effects such as fungal keratitis. Small sample size and retrospective nature of the study are the major limitations. Thank you.
So DSEK in failed PKs
Yes, sir.
has been an established procedure
Yes,
before
sir.
also.
Yes, sir.
What was different you were trying to say over here?
So it was just done in our own cases. That's why I chose to.
Any comment regarding the size of the graft that you have used?
So DSEK donor diameter was always smaller. We have kept it smaller. Initially, when DSEK was being established in failed PK, then they were saying that it has to be either bigger or the similar size, because it can conform well to the, even if the graft host junction is very irregular. But over the time, it has been realized that if DSEK donor graft diameter is smaller, then it is better. The rate of graft detachment is lesser in those cases.